I'm really interested in the relationship between autism, mental health, and the environment. Because I know a lot of us as educators and parents are trying to create environments for our children that are healthy. And still, I know myself, being somewhat autistic, and my son, who is diagnosed, we both have triggers in the environment very often. Garbage cans, I know, bring great anxiety to myself and my son. Plastic bags, and overuse of resources stress us and often cause us mental anxiety. And I'm wondering how much research is being done on this.
So it's a very good question, a very important point, that sometimes there might be the same experience or different experiences that contribute to the stressors that are in the environment. And I think there's, in terms of the research, people have talked a lot about the sensory aspect that can add to stressors, like the oversensitivities to texture and to kind of visual, kind of lights and kind of sounds. And I think from an intervention perspective, there's a few things that we know we can do. One is, there's a few things you can do when you think about those kinds of stressors. One thing is to ask, okay, how much of that is going to happen no matter what, right? That we don't have control over. There's going to be some of that no matter what's going to happen, it's going to pop up. You're going to run into a garbage can, for example. It's going to be there somewhere, or somebody's going to break out plastic bags. Less so nowadays, but those kinds of very individualized stressors, we can't control our environments all the time. So we have to we have to build that muscle or that skill set to tolerate that distress that we're going to experience. It's going to pop up in a healthy way, so that it's not too distressing, but it's still there. We also have to make sure we equip ourselves to be ready for that to happen, right? So having the right kind of physical and being in the right kind of physical and mental space for when that kind of stressor inevitably is going to pop up. The hard part is that we don't know when it's going to happen. So we kind of always have to say, how are we going to treat ourselves or support ourselves? The other piece is, I think that everybody should be allowed to have environments that are free of those kinds of stressors that you described, right? Kind of a place where you can get away from it, a place where you can kind of say, I know that in this space, that's not going to be an issue.
Okay, we have another question here.
Yes, I have a question regarding the mindfulness-based groups that you talked about, where the participants had found success because they were able to keep going. I wondered if those studies talked about how those individuals were able to do that. Did they find some groups in the community that they were able to connect with? What were their strategies that kept them going?
The limited studies that do exist, the ones that have presented a long-term maintenance of the things that they've learned, the things that they have in common is that they're all short in terms of the actual activities that have been taught. They're very straightforward or concrete, and they were practiced in the intervention time with a lot of regularity. So for example, they all kind of, the studies that do have up to even 2 to 3 year follow-ups where they're showing that people continue to use the activities that they've learned. They've done a 20-minute kind of activity during the training phase for 6 months every day. And then starting to fade out the clinician who is involved. And then only then, after that really period, they're able to see these kind of longer term effects. And they're not asking people to engage in hour-long meditation practices every day. So that's some of my observations about the literature that does exist. I haven't read any studies myself yet, or any papers myself. I'm sure they probably do exist to answer your question more specifically, where clinicians actually wrote about, this is what I know has helped people maintain what I worked with them on. Yeah.
Thank you.
Okay, and the question here is, does Dr. Weiss know of research into the effectiveness of somatic-based therapies for people on the spectrum, like somatic experiences or treatments often used to treat trauma in the body?
So I don't know of any trauma-focused kind I don't know of any literature on trauma-focused kind of therapy at the moment. We did a trial a while ago where we tried to involve adults doing CBT that wasn't trauma-informed, and I can say that it really missed the mark in terms of addressing those participants who had considerable trauma and were coming in. So but I don't know of any offhand.
Okay. So let's have this lady who's standing here.
I've always, I have a question for you in your research journey. Have you ever done a study that has been conducted by autistic researchers? And I know there's been normally reports like from the family and the clinicians. How much of your report, self-reporting do you have from people with autism about the effectiveness of the studies conducted?
So in all of our treatment trials, we have the people who are participating in them, if they're children or if they're teens or young adults, as kind of the respondents. That's one of the kind of areas that's more traditional. We also involve, with our teen or adult group, we also have them there's also a steering committee that kind of reviews the interventions and what we were thinking about doing before we did it, to give us advice on how it's being framed and the language around it, so they kind of help steer it. They're not the researchers per se on our research team, but they were involved in the planning phases of it. And as I said before, I think around equipping parents, but also in terms of equipping young adults or participants, it'd be nice eventually if those who were really successful in terms of participating in the treatment could help to be the ones delivering the treatment. But we haven't done that yet.
You've talked a bit about emotion regulation, and one of the things that I'm finding a lot is there been research to examine a link between personality disorders and autism? And I'm wondering if there's been any effectiveness with like dialectical behavior therapy, cognitive, there's a couple clients that I'm thinking of that look really personality disordered in their presentation, but they don't yet have that diagnosis.
So that's a good question around personality and ASD, and well, first let's talk about the DBT, or dialectical behavior therapy, for a second. If we think on a transdiagnostic way, regardless of whether a person has a diagnosis of ASD or a diagnosis of borderline personality disorder, or both, or neither, if somebody's presenting with considerable emotion dysregulation or difficulties with emotion regulation, considerable kind of challenges with social dynamics and moderating social dynamics, issues of crisis or self-harm, potential issues of self-harm. As a clinician, a lot of the tools that come about and the structure of DBT would lend itself very well to that kind of intervention, regardless of those kind of pieces. Certainly, you'd have to tailor the delivery of those and the conversations of those to the needs of that patient, kind of participating, how much of it's done individually versus in the group environment in a traditional DBT kind of context. So there's modifications there. It's hard for me, at this point, to pull all the studies that I like of what does exist. There are no specific reviews of DBT, as far as I know, that exist on the topic yet. But I think that's where this kind of point of being transdiagnostic really matters. And many patients who struggle could benefit from that kind of approach, even without a DBT diagnosis. The question of personality is very interesting. Some people have tried to create new dimensions of personality or so. I don't really see it that way. I typically see that if you could have autism and still be quite extroverted, or be on the dimensions of personality that we all think of as personality. I think that I see it as a dimensional thing. Some people are more oppositional than others, right? Some people are going to be more reactive than others. So I see it in that transdiagnostic kind of way.
You were talking about family, society, environment, individual. If there's been any research, or what your thoughts are about doing research with kids on the spectrum, teens, around mindfulness, etc., within schools, because it seems to me you can see them every day over time in their environments.
There is work on cognitive therapy, bringing cognitive behavior therapy to students with autism in schools right now that's being published. There's work on mindfulness-based therapy in schools, taking a whole class approach, and also a school-wide approach where they're bringing that to the level of the educators, not to the level of the students. I don't know of a specific one that's married now mindfulness for students with autism individually in a class, but it strikes me like the approach, a whole classroom approach, where some of the students might be on the spectrum, might not be, right, and bringing it in that way with individual tailored pieces as needed would make a lot of sense.
Okay, the next question is, what does the research indicate regarding concurring mental health issues in siblings of children with special needs? And how do you incorporate siblings in the social aspect of the biosocial approach? No, the biopsychosocial approach to care.
So there's a quite relatively sparse literature on the mental health experience of siblings on the spectrum. The literature more broadly seems, from my kind of view of it, and there are other experts I'm sure in the room that would speak to that as well, talk about the positive gains as well as the negative kind of experiences of being a sibling. That it's not one or the other, or those two dimensions are not mutually exclusive. They're not on the same continuum, so to speak, that people want to be recognized for both the positive experience of being a sibling as well as the challenges associated with that. In terms of the treatment, this mental health treatment literature that I've talked about so far, I don't think any of it has involved purposefully, in a methodical way, siblings in terms of as another participant group. So it sounds pretty under-recognized in terms of a role that it can play.
Thank you. Over here.
So I've never gotten a chance to actually talk to a researcher about their own research. And I was curious about your study on the bullying. And I was just curious whether or not there were measures for maternal mental health, and whether or not you would expect a similar trend if there were a control group, for instance, with children not on the spectrum.
So it's a great question. There was, we typically, as part of our standard assessments or our standard kind of surveys, involve an opportunity for parents to report on their own mental health. So yes, in terms of usually in a very brief way, using a brief kind of questionnaire, so it's not a rigorous determination of who has a mental health disorder and who doesn't. And there certainly is that typical association we see between high levels of parent distress and high levels of difficulties in their kids. So that answers, that's kind of to your first point. In terms of a comparison group, our study did not have a control group or a group of kids not on the spectrum. But the graph that I showed you was actually inspired by an excellent study by researcher Bose and colleagues. I usually remember where they're from, but I don't remember what countries they were from, that looked at the same thing of parental warmth, and actually in that study, sibling warmth, as it relates to being a resilience factor for kids without autism who are experiencing bullying. So, and they found similar, if not stronger, kind of results with their much stronger methodological design. So the pattern, in my view, I would say, isn't exclusive to autism.
Thank you.
Okay, now over here on the left.
Yes. My question is, I work with a lot of children in infant mental health, and only some of them are on the spectrum, but they're often not diagnosed because under 5 or 6. So I was studying in the States, and at age, I think 2 or 3, in the elementary schools, they were anybody who needed assessment or they were querying, through the school psychologist, they had a system for early diagnosis, prevention, etc. So I'm just wondering, and I thought I heard maybe they're even diagnosing earlier now, so I'm wondering for infant mental health, what's the earliest that they're being diagnosed? What's the best interventions at this time for that population?
So so the question about early diagnosis, not of mental health problems, but I think you mean in terms of identifying autism
the
early.
ASD part, yeah.
Yeah, so there's been some excellent work across the country looking at developing early infant kind of based tools around early identification and even earlier identification of autism. From my understanding, and again, there are other clinicians and researchers in the room, from my understanding, that these kind of tools seem to show reliability by 18 months of age, but that many people are obviously identified far much later, depending on what their presentation. And even earlier, as early as 12 months of age, infants have been identified, but that there's some challenge around using the tools in terms of their reliability at that point. Certainly when it comes to treatments, you guys are at can I mention? You guys, Vancouver, with the work that Dr. Pat Miranda is doing, kind of in early parent coaching for parents of very young children, either identified with autism or at risk for autism, speaks to the opportunity that exists here in Vancouver, but also to a growing trend of helping parents and even pre-diagnosis when children are at risk for social, communicative, and behavioral difficulties that we tend to see emerge later in autism, that we might be able to influence development and equip parents and equip very young infants even before they get a label.
Yeah, just to link it with mental health, that's sometimes a challenge, is it mental health or is it something else? So that's where the kind of question came from. So you mentioned Pat Miranda, which I will look up. Is there any other key resources, websites, or sort of experts that you recommend I could do more research in?
So
in
there
that
are
area?
There are a lot of, maybe that's probably something afterwards we could kind of talk about kind of off stage, but there's considerable work around very early intervention for children with autism, whether it's the social ABCs that's coming out of Holland Bloorview in Ontario, for example. None of these have to do with assessment of is it autism or is it something else. I'm really more talking about if children are at risk for that kind of pattern of difficulties, infants. Projects that aim to support parents to do something about that very early on.
Okay, great. Thank you so much.
And any resources that we pull together we can place online afterwards. So if Dr. Weiss has things he'd like us, because I'm sure we all experience that, why didn't I think of that particular reference? So we can add those later online. The next question I have also online is, what would Dr. Weiss recommend for helping teens learn affect regulation, which is not solely a cognitive approach?
So affect regulation is, we know we can actually do a good job not just using cognitive means, but through a behavioral approach to kind of teaching somebody to express themselves and experience their emotions in a healthy way. So whether it's, and most cognitive behavior therapy approaches with children and adolescents on the spectrum are almost like what I like to describe small C, small cognitive, and big B in terms of the approach, so big behavior. So it always typically has both. So I think that there is a group, so it's really much less about reframing your thoughts or thinking differently about a situation or thinking about the consequences of your actions going forward, the cognitive pieces, and much more on helping somebody experience success in situations that elicit distress. That is to actually be in a situation that elicits distress and experience it over time without having to react in a very maladaptive way. As an example, so just that's a really jargony way of let me say it in a non-jargony way for the person on there. We know that across many different mental health difficulties, whether it's anxiety or depression or anger, that one of the mechanisms that help people be successful in treatment is if they systematically and in a step-by-step way are able to go into those situations that cause distress for them without having problematic reactions as a result. So just being in that situation, sitting in that situation that's distressing, over time, eventually that distress lessens. If we don't do things like try to escape from it or we don't try to compound it in some way, right? When we talk about anxiety, for depression or sadness, people with a lot of depression typically avoid, for example, pleasurable activities. They avoid being in a social world. They tend to withdraw. So it's almost like slowly exposing them back to the experiences of pleasure, but being and sitting in it is a very behavioral approach. It's extinguishing the association that they otherwise have between that situation and the negative feelings, right? So through that experience of sitting in it and experiencing it without trying to necessarily even kind of think about it differently, the strength of that impact of it lessens. But you have to do it in a very systematic way. We can't jump into the deep end of the pool. Right? We have to wade in kind of slowly at a person's comfort level.
Okay, thank you. Over here.
Just regarding the R word and community training, I've heard there's a lot of controversy now about the term special needs, and I was wondering what your view on that term and similar ones is and how it affects individuals with ASD.
Wow. I appreciate you kind of saying that. I hadn't thought about that before kind of you brought it up right now. So I think I'd need some time to think about that a bit more, in terms of my personal view on that language. I would say that the choice of how we describe, and I'm personally still I have my own internal debates about the best way to talk about differences or disability, and I'm not fully consolidated in terms of what the best way is for me. I know that the few studies that have spoken to autistic adults and spoken with family members and clinicians and asked them what's the best way to talk about autism, for the most part comes up with many different answers depending on who you ask and individual preferences as well. I think obviously on the extremes of it, people rule out kind of pejorative language, but it always seems to be in flux, right? It seems like there's always an evolution of the best way to respect a person's difficulties and differences, and at the same time acknowledge them for what they are.
Over here on the right, please.
Hi. My name is Tracy. I'm an occupational therapist that works in public health, and so I see a lot of young adults or adults transitioning that are into our service. And so just talking about community, I have a really hard time where health or Ministry of Health is saying, like, we're only going to deal with health. And so we know about, transitioning to housing or employment and those being social determinants of health. Through your research or through your knowledge, is there anything that we should be systematically measuring, strategically measuring, to showcase the value of these interventions, or what we should be really documenting to highlight the need as these individuals move forward into adulthood?
Okay, that's an excellent question. They're all excellent questions. What would I measure if I were you to document the need or the impact? Seems like an important piece would be, from my opinion, would be that I would want to know about the impact on a person's quality of life and their family's quality of life, using those measures. Now, is that what policy makers, decision makers within government might use as the prime kind of reason for funding something or not? I don't know. I kind of suspect no.
I was wondering if you could translate that to dollars.
Yeah, so I think that those are two different, right? Yeah. Those are two different points. Personally, I think where I would want to see change and I would want to document the need during periods of transition or challenges with kind of community supports would be how it's impacting a person's quality of life in meaningful ways and their family's quality of life. That's what we're in this for. If we're talking about kind of informing decision making, I think it's important to link those kinds of programs to changes in, for example, healthcare service utilization over time. If you are able to document how involvement in these kinds of relatively less costly community supports is associated with fewer emergency department visits, fewer inpatient or outpatient hospitalizations for mental health care and so on. And the opportunity to do so from a policy and planning perspective does exist, and it has happened. I alluded to, or I briefly touched on our work with HCARD looking at administrative health data. It's conceivable with the right kind of linkages that you could examine community participation, or even for that matter, educational education systems if they're properly linked, and the characteristics that people have in those environments, and more costly kind of use of healthcare services. So from a decision-making perspective, I think that would be an important part also. Documenting what are the needs, what are families asking for, right? What is the impact on the quality of life, and how does it shift resources in an effective way to more community, less hospital-based kind of resources?
I'm an autism support worker in the school district. My question is about, have you done any research for people that are nonverbal or any alternative communication with your research, or any strategies to support them more in the community?
So the research that we've done, the intervention research that we've carried out at York University has not included people with those kinds of difficulties. I don't think you're going to find one intervention for everybody. So we're picking the ones that, for many reasons that kind of fit for us, not because I think that other interventions aren't important. It's just what we've picked. Yeah, so I think it's just a part of the puzzle, a part of the, not the full kind of piece.
As well, one more brief comment was, I work with some boys that have severe autism with aggression and mental health and other psychological disorders. How can we help them with more calming down their behaviors, or how we can support them more in the community so we can help to de-escalate them and make them more successful in how they are?
So there's two things that I'll say from my view of my high-end view of the literature, right? Not knowing these kids or anything, but it seems to me like individualized, consistent behavioral supports that help to create, antecedent conditions, create the right kind of environments, the right kind of prompting to promote kind of success, right? And replace those kinds of challenges, I think is very important. But I think consistency, I think monitoring those kind of those targets that you talked about is really instrumental. And in my view, a lot of the things that when things start to go right, you need the resources to stick with them. Too often things start to go well. I've seen and then people get pulled away or resources get moved elsewhere.
Yes, exactly.
You're talking about situations of somebody with very high needs. I think we have to think about consistency over a longer term period when we find something that's working.